Welcome to the latest in our series of TopMedTalks 2. In these podcasts, the TopMedTalk team is in conversation with global thought leaders in perioperative care. TopMedTalk.
My name is Desiree Chappell. I'm host of TopMedTalk today, joined here with my co-host Monty Mythen and Joff Lacey. Thank you guys for joining us this morning. We want to welcome our special guest who spoke during the first session today here at Anesthesia 2018 about big data in anesthesia. That's Professor Iain Moppett. He is a professor of anesthesia and perioperative medicine at the University of Nottingham. Iain, thank you so much for joining us today.
Thank you for having me.
Yeah. So we're just going to start off by asking you a little bit about your background. What are you doing there at the university? And just give us a little bit about that.
Okay, thank you. I'm the professor of anesthesia and perioperative medicine. My research interests are around care of the older patients in the perioperative period, particularly patients with hip fractures, and I've done work developing risk stratification tools, the Nottingham Hip Fracture Score, and running some clinical trials in that. I've also got an interest in patient safety, particularly around understanding never events and how we can improve patient safety in the perioperative period.
Great. Well, just to jump into what you were presenting this morning, one of the first things you were talking about is using artificial intelligence or AI. And so how do you believe that's going to start driving care and driving big data here for us?
I think I'm wary of talking about AI in the sort of self-driving cars.
Didn't work out so well.
Some bad stories. Interestingly, some hype about the bad stories as well. Human error involved in those. But I think perhaps anaesthetists don't realise how much we use intelligence to support what we do. So things like, even the simple things like driving total intravenous anaesthesia with the models that we use there, we're already comfortable with the fact that there's a black box which is giving us some idea of what's going to be happening. So I think we've already got those tools out there. And again, there's some tools which we don't necessarily see within directly within perioperative care, which impact on what we do. We forget about how did the stuff arrive in my theatre? How did I get a laryngeal mask, or didn't I get a laryngeal mask into my theatre? And so there's a lot of companies using an awful lot of data already, which is actually driving a lot of healthcare. And perhaps we as physicians are a little bit slow on that because we like to. We're confident in our abilities to assimilate lots of data and recognise patterns for ourselves, but actually, I think there's opportunity to really harness that to understand more about our patients and about what's going to happen to them now, what's going to happen to them in the future, enabling those discussions. But I think it's important not to forget that all of those data are fundamentally supporting us to do an interaction between two human individuals.
Yeah.
And that we mustn't forget, no matter how much data there are, that's really important.
Yeah, absolutely. And I think sometimes we do forget that whenever we're in practice. So you were talking about analyzing big data and how we use those numbers. How do we do that in a meaningful way? I mean, there's just so many numbers out there and so many data sets. Like, can they actually change practice? I mean, how are we going to use that in the future?
The fundamental mathematical questions, I think we actually go to experts to do that. I don't think it's not for this is outside the territory of anaesthetists going, I can work out the mean of this and I can work out the mean of that. This is it's getting experts, and they exist. There are an awful lot of very, very clever people working in data science, and we should be using them. I think where we need to get involved with that is helping those data scientists understand what those data represent. As I presented in the talk, for instance, even describing what a general anaesthetic is or what a regional anaesthetic is, we're not very good at writing down what that actually is. If you go to sedation, what is sedation?
Right.
So understanding those, we need to help the data scientists understand what the data mean, what they might mean. We need to help work with the data scientists to get those data back out in a meaningful way. I think the last thing any of us want is more yet another table,
right? Exactly.
Yet another PowerPoint
table.
presentation telling us what to do.
And In my experience, is those data scientists, the professionals, have an insatiable appetite for complex sets of data. They really feed off it. And then at the back end of it, the objective is to convert that into images that we can absorb quickly. You showed us some heat map type of maps and stuff. One of them in particular was about, are they scones or scones?
Scones. I've got a good life expectancy. They're scones.
So people should look that one up, shouldn't they?
They should look that one up.
Where'd you find it?
I can't remember.
www.sconemap.com.
Yeah, effectively, yeah.
We'll try and find the link for you, but that was fantastic. Do you understand the scone thing, Desiree?
Actually, I don't. It's lost over me in the US. We call them biscuits. So
the distribution towards more the north of the country, which way around is it?
Yeah, the north of the country, by and large, pronounces as a scone, I think. And that is associated, I'm sure it's not causal, with the fact that there's a lower life expectancy. Whereas further south it becomes a scone.
Yeah. So our kids were taught that before you've eaten it, it's a scone, and once you've eaten it, it's scone.
Classic.
Sorry.
But yeah, I helped to.
Oh yeah.
But Iain, on that, you're talking about the importance of consulting with experts and knowing exactly how we're going to deal with the enormous amount of data. So, in that respect, are we ready yet for big data? Like, have we actually laid the ground rules and worked out what we're going to do, or can we jump right in already?
I think I might be a bit pessimistic on this one.
And say no.
Because
that's my feeling. Yeah. That we haven't. We're kind of getting in. We're in that kind of over enthusiastic phase.
Yeah, I think. Well, actually, I suspect we're in the cynical phase, which is before the enthusiastic phase. But the reason I say no is that I'm not sure that we have that data literacy within the profession. We like things to be black and white. We like things to say either this causes this or it didn't cause this. And particularly in anaesthesia, we know that if I give propofol, the patient goes to sleep. It's not a 75% of patients on a given day with a certain mix of propofol might go to sleep. Yeah. And actually those caveats around big data, again, understanding what the data are that go in, that they're models, they have biases. It's not about putting someone into a definite category or someone into another category. So I'm not sure we fully understand. We have that literacy, and I think that's where we've got to work with the people who analyse the data, put the data out to get it better. And I'm an academic. I'd argue perhaps the journals have got a place to play in this because they are hidebound by producing tables of numbers, which have very little. Don't really mean very much to someone that reads it.
Yeah, so a lot of the journals are using infographics. Yeah. And, one of the things I was, thinking about is how do we most efficiently communicate, and is that going to help with buy-in of using these, big data?
So you showed an example from the recently published perioperative quality improvement program first report, which I've seen a few times now, which has those lines that change in size and shape and colour that go from the left to the right.
Yeah.
And they kind of, you only see them a couple of times and you're really getting those messages coming through strongly. Can you elaborate on that a little bit? Because people should really, I think they should look those up and I got those.
Yeah, I think they're called alluviograms or alluviograms to do with rivers. But anyway, so the idea is that you take your distribution of people at the start, and then something happens, and then you look at the distribution of people afterwards. But what you see is the change. So, what you're referring to, for instance, from PQIP was people who had no pain before their operation. Then 6 months later, how many of those still had no pain, and how many of those had worse pain, and how many of those went from lots of pain to being better? And the place we see the most often are to do with voting intentions, general elections, that sort of thing. People changing their votes. But actually, I personally think they're quite a powerful tool. As you say, you see the data once, you get the qualitative message, which is the important bit. It's not around whether 25% or 26% changed their mind. It's around, did a large group stay the same, and how many got better and got worse? And I think, so I think there's a role for people at the college, within the profession, to get better at presenting those data. We can put all the data in, but if the data don't come out in a timely, understandable fashion, then it's essentially it's pretty useless.
Another topic I wanted to check in with you on was some of the concerns that cynics, let's say, of big data, or the concerns, not so cynics, but people who aren't quite ready for it yet, is obviously, and it's very topical, is privacy. And obviously, in order to make big data successful, I imagine we need to make it very accessible. Do you share those concerns about privacy, particularly with healthcare related records, or is that something you think that we can resolve reasonably straightforward? What's your opinion on that?
I think the privacy concerns are completely legitimate, and I think nobody should ever dismiss those as unfounded concerns, because particularly with the scale of data, all it takes is one data breach or someone just being careless, that's the most likely thing, to have a huge impact on individuals. And we might think it's a trivial thing, but actually to those individuals it's really, really important. So I think it's absolutely fundamental that we get that trust right. Equally, I think we have a responsibility to society, which is to say, how do we actually improve care for the good of society? And and we need to have that conversation. We know from stuff that happened in the UK sort of 5-6 years ago that when we don't have that open and honest conversation about things, then it goes wrong, and people lose. Trust is very, very quickly lost. But that needs to be a proper open discussion, not something which is done behind closed doors, not something done in government departments, not something that is done by people shouting across sort of barricades at. So I don't think there's an easy answer, if I'm honest. Truly anonymising data is very, very hard. And there may be essentially a myth about anonymising data. Yeah. It's on a spectrum, and so privacy is really important. It's not an insoluble problem, but we need to talk about it openly.
So we're leaking either deliberately or inadvertently information about ourselves the whole time. We've all been tweeting and social media and communicating, even speaking on the phone, it would appear. Is there any signals of that being exploited for the greater good in healthcare? If they can work out that I'm thinking about buying a garden shed, could they also work out the fact that I might be developing some psoriatic patches on my skin and my eyesight's going, and maybe we can pull all that together? And was that a bit too scary?
They're doing that on Facebook already.
So the best example of that, which I'm not an expert on, was the Google flu tracker from about 10 years ago, which showed sort of both the good and bad bits, I guess, of using that approach. So they had initially quite promising that they were quicker than CDC in the States at predicting flu outbreaks based, depending on whose report you read of it, people searching for I've got a snuffly nose. So initially some very good results and some interesting stuff. They some quite bizarre things they seem to get in the algorithm about baseball teams. I don't know the association between baseball and flu. But also that, so initially quite good results, but then what they found was it needed recalibrating, it got spurious results, and this whole issue of reproducibility, that big data should be critically appraised in just the same way as any other mechanism which we're using to make a diagnosis or to support our decisions. So, and essentially it's fallen by the wayside. It on that Gartner chart of it hit hype and then it hit despondency. There probably is real value in it.
Yeah. Just using it in a meaningful way. Well, last question here. So one of the things I always like to talk about is how we implement and how we use these things that we're talking about on larger scales into practice. And coming from anesthesia and some of the work you've done with patient safety and hip fractures and things like that, how are you utilizing, big data and these numbers and information that we gather from that in your practice?
I think there's a few bits. One is actually I think we're not using it.
Okay.
That's the problem. As in we're not getting the data in, and that's.
Do we have it?
Yeah, I think we do have more data than we think. Mm-hmm. Although I've sort of mocked our specialty that we can't decide what general anaesthetic is. Well, actually, I don't care. Yeah. Because actually we should be getting more granular about what we're doing, not just trying to arbitrarily say, well, that was a general anaesthetic with a plus or minus a regional block. Let's actually say, well, that was a TEVA anaesthetic. And actually, those data we should be able to get those data in. But that involves people actually culturally saying, part of my good care is somehow getting those data in on a regular basis. It's not about doing snapshot audits of 50 patients, and it's about saying, year in, year out, we've captured 60-70% of the patients having this procedure. This is what we know happens. So, for instance, we did that. I'm going to innovative talk about what I know about with the sprint audit around hip fractures. A lot of data in, a lot of these is putting a lot of effort in. We couldn't continually do that, though we should be able to. But what we did show is that the association of essentially of low blood pressures during surgery and bad outcomes. And those data are now starting to drive improvements. People are saying, actually, we're not quite sure whether it's cause or effect or association, but we think the hypotension is more common than we want it to be. Could we do better? So we are starting to see those data. But there is something like getting perioperative physicians, anaesthetists, more used to using risk stratification tools. They're better, I think, than we are. But we don't like to admit in front of a patient that actually I'm going to plug some numbers in, this is going to give me an estimate, which I'll then individualise based on the person I'm seeing in front of me. So culturally we need to change. We're saying let's put data in, but with a compact with the people we give the data to, that it's going to come back in a meaningful way quickly enough, not 5 years later, which is our current trend.
Well, Iain, thank you so much for sitting down with us today, and thank you for the great presentation earlier. It was wonderful. And here at TopMedTalk, be sure to follow us on Twitter, Facebook, LinkedIn, all your favorite social media platforms, and look us up on TopMedTalk.com and check out what's happening here at Anesthesia 2018.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.